Assalamu alaikum. I hope that all of you are safe. My name is Dr. Ebtehal Muhammad Ali. I am an assistant professor in psychiatry, and today I'm going to talk to you about psychological assessment and care and how to communicate with cancer patients. As we all know that any person, if he had the diagnosis of cancer, this is a devastating diagnosis. It leads to a lot of psychological problems to the patient himself and to his family as well. A lot of studies has been done in the past decades on the effect of cancer diagnosis on the patient and especially the psychological consequences from the stress and anxiety, post-traumatic stress and everything. Elizabeth Kubler in her book Death and Dying described 6 emotional stages that each person passed through them when he got the diagnosis or have to deal with cancer. The first one, or the first stage, is the stage of hope and anxiety, and she described this stage as the stage where there is still hope that I have symptoms, and those symptoms I don't feel that they are not right, but I'm hopeful that it will not be something grave or dangerous, and that the diagnosis is not established yet, but still there is an anxiety because the possibility of having a diagnosis of cancer is still there. The second stage is the stage of denial. It's no, it's not me, and this is when the diagnosis is ascertained, okay, you have cancer. Usually this stage is associated with increased risk of suicide. Denial at first may be protecting from the emotional impact of having such a diagnosis, but if it lasts, it have a bad impact as it may lead to hindering the starting of treatment and the compliance to it. The third stage is the stage of anger, where it's why me? The patient seeks for, I want to know why, so for causes and explanations. He may interpret it that this is a well-deserved things. I was bad, and I've done bad things in my life, and this was like a punishment from God. Or he may think it's undeserved, so why me? Why me? I have a lot of stressors in my life, and on top of that comes also a diagnosis with cancer. So out of this comes the anger, and the anger usually is directed to the surrounding, especially the medical staff. After that comes the negotiation, when the patient starts to negotiate with his God. So please, if I came out of this, I will be good, I will do that and this. So it's like a stage of negotiating with your God, and a lot of promises because he wants to be good and to be well, and this is the most effective stage to start your intervention. The fifth stage is stage of depression, when the patient say, okay, yes, it's me, I do have cancer, and the signs and symptoms cannot be denied anymore, and it's progressing, and maybe I started treatment and the treatment is not that effective. The sixth stage is the stage of acceptance. This is the final one, and not all patients pass through this stage. So those who are highly unstable, especially emotionally unstable, usually they don't reach that stage. Also, that stage can appear with the final stages, when okay, this is there and the patient is accepting everything, and that's why it doesn't happen to all patients. As we know, cancer has physical consequences, like it leads to disfigurement, pain, fatigability, disability, but also it has a psychosocial effect or consequences. Psychologically, it may lead to the grief. The one grieves himself, anticipatory anxiety, so there's uncertainty and he doesn't know what is coming. Would I be good responding to treatment or not? What would happen? How long will I live? So a lot of questions appear, and idea of this began to appear in there. So he thinks about it a lot, and this may lead to depression, especially if there's a change in the role of the person or there is a disability or handicapping. Also, it affects him socially because people may treat him differently. Certain communities may have stigma towards the cancer patients as if it's an infectious disease. They may avoid him, or there may be grief in the people who are surrounding him. And anxiety usually appear out of the fear of death, fear of surgery, fear of therapy, disfigurement, dependency, incontinence, pain. So a lot of stuff that's related to the disease may lead to the fear and the anxiety. And usually fear and anxiety is more in the younger patient than in the older one. Also, depression appears when there is fear of loss, separation, disability, handicapping, pain, fear of the radiotherapy, chemotherapy, and there's consequences. Or when the patient started the therapy, there are side effects and he's not responding well to treatment. This usually leads to depression. There are certain risk factors that help a certain person with the cancer disease to develop depression. Those of you have past history of depression or family history of depression or suicide, so there are increased risks that you may develop depression as well. If you have certain personality factors if you have certain personality factors like external locus of control, meaning that you usually blame others or certain circumstances, something or someone for anything that goes wrong in your life, so you are never responsible for that. This makes you a candidate for depression when you have cancer disease. Also, if you have problems with expressing your emotion, if there are concomitant stressful events, or you live alone, or you have poor social support, pain, unrelieved or severe pain, if there is a physical disability or impairment, all these factors may help you to develop depression. The sense of guilt, as I said before, may arise from the sensation that this is a punishment from God for bad thing that you did, or that you feel guilty that you are dependent on others, and your family maybe cannot tolerate the financial problems related to your illness, your therapy, or you cannot work anymore, so you feel you have this guilt sensation. Usually guilt is associated with anger, and the anger to a great extent is directed to the medical stuff. That's why you have to know how to deal with an angry patient. Patient passing through the journey of cancer usually pass through existential crises. The first one he met when he had the diagnosis of cancer, so the possibility that I'm going to die is there. Then he started to receive treatment, and the treatment is responding. He completed treatment. He's happy, or she's happy, but there come the second existential crisis with the worry that would I survive it? Will it return again? So there is the worry, but the patient continued his follow-ups, his follow-up visits, investigation stuff, till he got the recurrence. And the recurrence was an increase in anxiety that this is likely I'm going to die, so probably there will be depression and anxiety. And what even worse is that the disease would advance or metastasize, and you reach an advanced stage or a terminal stage where the idea of I am dying is there. Okay. Usually with each of those crises there is a problem related to the cancer, and that it's associated with an anxiety and probably with depression as well. To communicate with patients with cancer, you have to have the basic communication skills. And as well, besides the basic communication skills, you should know how to deliver bad news. because this is bad news. And at the end, you should know how to disclose information about the prognosis, how to tell your patient the prognosis of his disease without giving him false hopes, and how to transit from the transition from the curative stage to the palliative stage or the end of life care. Basic communication skills is very important, so you should know how to engage with your patient, how to talk to him, how to give him sufficient information, how to educate your patient about his condition, and how to let him express his emotions without fear of being judgmental or of judging him or yelling at him. Please let him express his emotion, whatever the emotions are, and listen carefully at him. So you invest time and effort in giving him sufficient information, in listening to him, in addressing every emotion or worry that he have, and in giving him the sufficient information and options about the treatment, and communicating with the patient and his family as well. Delivering bad news, as we all know it, the spikes. But what makes it difficult for physicians is that sometimes the oncologist is not well trained on delivering bad news. Sometimes they experience negative emotion as fear or anxiety that he will be blamed from the patient or his family, that the treatment didn't work, that treatment that he suggested didn't work or was not working. Sometimes physicians react to the emotions of their patient by giving them like false hopes or reassurance, which is not correct. Also, sometimes they omit certain information because they think that the patient cannot handle it or tolerate it. Also, some patients may handle the information through denial or blunting. So he avoids asking questions, he appears optimistic about the outcome, and he destroys the information that you give him. So you should be aware about that and how to direct him without giving him false hopes. The specs are the setting. So you should prepare the setting very well. So in a quiet, closed place, your phones are shut down. There's enough time for the patient. You check that he is comfortable. Does he need or she need anything to drink? Does he or she need anyone of her or his family to accompany him? And you start by assessing the perception of your patient. So what do you know about your condition so far? And follow that the invitation, asking the patient, so do you want me to tell you everything in details? And this is very important. You should ask the patient if he wants to know the details or not, and then you start to give him the knowledge of the information. And please, you give the information in chunks, small pieces, and you avoid jargon words or scientific terms that he will not or she will not understand. And you check after giving each piece of information that the patient can understand you very well, and you give him or her a little space to like digest or grasp whatever you said. If the patient expresses emotion, please let him express his emotion and be empathetic through the process. At the end, you give a strategy for therapy or options for treatment, and you summarize the whole plan for the patient and his family. So this is very important. Spikes are the setting, perception, invitation, knowledge, being empathetic, and at the end, summary and strategy. So the idea that you talk to your patient, usually most of the patients wants to know the complete and accurate information related to their condition. And although that most of the patients wants to know everything, you should ask the patient at the beginning, are you someone who wants to know all the details about your condition or not? And you don't force him to know things that he doesn't want to know. Your patient satisfaction is very important, and usually you get this satisfaction if the patient perceived you as an interested person. So you give him more time, you give him more effort, and you invest time in explaining everything to him. You choose a proper environment, you like your office, and you were not annoyed by his questions. He can understand everything that you said, so your language was understandable to him. So if your patient finds you that person, he will be satisfied. And this is very important, because why do we need the patient to have sufficient information about his condition and be satisfied? Because when he have this information, this gives the patient a sense of control. So it would reduce the anxiety and decrease the ideas of uncertainties to some extent. He will trust you because you didn't hide anything from him. You tell him everything in a reasonable way. This will create realistic expectations to the patient, and this will help him to participate and be compliant on treatment. And generally, this creates an atmosphere of safety and security. This is very difficult if your patient reaches an end stage or a palliative care stage. So usually this stage is full of worries. He's worried about his children, his beloved ones. He's worried about being abandoned. He's worried about being more disabled, handicapped, that he will depend on others, like going to the toilet or doing basic living activities. He's worried about his physical appearance that may deteriorate, about pain that may get worse. Maybe he's worried about his mental condition. Will he be aware, or there will be a decline in his mental abilities? Worried about losing control. There are a lot of worries about quality of life, dignity, about having a good death. So all these worries that you have to deal with when you deal with a patient in this stage. So communication helps you in this. Good communication in that you establish a rapport with your patient, so there is a relationship, and this relationship helps you to deliver the information that you need to your patient in a way that he understands it. And providing this information about the illness and treatment will help your patient to be compliant in treatment, and being empathetic through the whole process will help the patient to trust you and to continue to be compliant on treatment. And usually it helps you to enlist the patient and his family in the treatment plan and in every step through the way. Usually having this good communication will help you to get your patient satisfaction. He is compliant on treatment, to increase the patient knowledge. He could help that in research or clinical trials. It helps you when you the transition from a regular curative into a palliative care, and it decreases the stress and burnout on the oncologists. This helps an approach called a patient-centered approach. In the patient-centered approach, the patient is the center of our care. So our mission to help him to get better, to get the best treatment ever, and on doing this we address everything related to the patient. So his physical, emotional well-being, spiritual well-being, his family's concerns, values, and usually the patient and his family are participating in the decision-making process. They are welcome to participate in the care of the patient. Usually there is full transparency and delivery of information. We have emotional styles related to decision making of the patient. The first is the passive decision makers. Those usually allow the physician to take decisions for them. They respond more to the caring attitude of their provider, so they want them to take the decision, to take care of them, and they will not participate in anything. The avoidant one differ from the passive one, that they are in a state of denial, and this may not only they will not take a decision, they will may be delayed in participating in the treatment plan. The panicked patients are so fearful when they are confronted with a diagnosis of cancer, and that fear or anxiety or panic may not allow them to participate in decision making, so they are so afraid to take decisions. The rational one, usually they ask for information, for options, and they are fully engaged in the decision making process. The important outcome of communication with your patient is that you will get the patient satisfaction, you can get the informed consent so you can start your treatment, and this will help to decrease some malpractice claims because he know everything from the start. He participated in the decision making, the patient and his family, and he's aware of every step through the process. At the end, I like to share a beautiful quotation about life. It says that life is a very precious gift, and unfortunately you don't truly realize it until you are fighting to stay alive. So we don't appreciate the preciousness of our life till it's threatened. Please stay all safe, and thank you.